Good evening to everyone and welcome to today's wonderful evening with Dr. Murli Bharadwaj. Rheumatology, nephrology, at least three questions in nephrology, two questions in rheumatology, sure shot out of 200 questions. So in the next couple of hours, 5 out of 200. How much? It is 1/40th of your preparation is over. Are you ready? Good. So the most common question asked in the exam, the NEETPG pattern is that of SLE. So what are the screening tests for SLE ANA? Lupus nephritis has a strong association with anti-dsDNA antibody. And what is specific for SLE is anti-Smith antibody. Recently they asked in the INI-CET exam, antihistone antibody is typically found in the drug-induced lupus, is what we need to remember. Antiphospholipid antibody lead to hypercoagulability, and classically SLE is an immune complex disorder, which is type 3 hypersensitivity reaction. That's the reason the complement become exhausted. That's the reason there is a low C3 and C4 is what you need to remember. And all that hemolysis that you see in SLE is autoimmune. That's the reason there are autoantibodies. Direct Coombs positive hemolytic anemia is characteristic of SLE. Now let me ask a question. If you don't answer, what will you do? You have to do night out to do revision. But I'm sure you will answer. Takurani ji, what is the hematological condition where Coombs negative hemolytic anemia will be there at birth? Oh, no. What is the condition where Coombs negative hemolytic anemia with a massive splenomegaly is present at birth, where you also do cholecystectomy? Huh? Oh no. Oh no. I told very clearly this point. Their hemolysis is because when that cell RBC is passing through the spleen, it becomes slaughtered. It is due to spectrin deficiency and kairin deficiency in the red blood cell membrane. There's only anemia. Huh? No. Huh? Hereditary spherocytosis. You said that? At least good. Coombs negative hemolytic anemia, because there the hemolysis is not because of any autoantibodies, it is because of that spherical RBCs passing through the spleen, which is responsible, is what you need to basically remember. Shailesh and everybody who are all online, thanks for joining the session, doctor. Yeah, we were a little slow today, but late arrival, but I'll give you the latest things for the NEETPG. Yeah. Can the online students can punch the voice loud and clear for all of you, doctor, please? ESR is elevated. What are the manifestations of SLE? Malar rash, which spares the nasolabial folds. Then what is characteristic of the SLE arthritis? All inflammatory arthritis lead to erosions, like psoriasis, rheumatoid arthritis. But only inflammatory arthritis, which is non-erosive, you don't find erosions when you take X-ray, is SLE, is what you need to remember. There is a lupus nephritis, which determines the prognosis in SLE. Ultimately, nephrologists decide the fate, whether a SLE patient how long he will survive. Lupus can lead to neuropsychiatric lupus where they can present with psychosis. And also the steroids which we use to treat SLE by themselves can lead to psychosis. That's called steroid-induced psychosis. There is a pleuritis, pericarditis with effusion because of the serosa involvement. And the autoantibodies can destroy the RBCs, WBCs, platelets, all the 3 cell lines after they are produced from bone marrow, leading to pancytopenia. A lot of times, if pancytopenia is due to aplastic anemia, you find a hypocellular marrow and pancytopenia. But there are only 2 conditions where there is a pancytopenia but a normocellular marrow. What are the 2 exceptions? SLE, because it is all peripheral, autoimmune destruction, and splenomegaly patients. They have a pancytopenia with a normocellular marrow. But most of the causes of the pancytopenia are all due to hypocellular marrow, is what you need to remember. Similarly, there will be painless ulcers in the mouth, Raynaud's phenomena, where there is a vasospasm triggered by the cold. And what are those verrucous, sterile vegetations on the valves? It is called Lippmann-Sachs endocarditis is the classical feature. And because of the antiphospholipid antibody, which is often associated with SLE, there will be recurrent abortions. So when your patient has recurrent abortions history tomorrow, Dr. Akshara, MD, DM, there's no DM in gynecology obstetrics, no? What will be there to do DM in gynecology obstetrics? It is the same delivery of the babies and the same pelvis, same uterus, no DM. Gynecology itself is a super specialty. All right. Now, how do you classify the renal involvement in SLE? Minimal mesangial involvement is class 1. Mesangio-proliferative glomerulonephritis is class 2. Focal proliferative is class 3. Diffuse proliferative is class 4. Membranous is class 5. And sclerosing glomerulonephritis is class 6. The 6 classes. Recently, in NEET super specialty exam, they have given most recent exam. Diffuse proliferative glomerulonephritis, image-based question, and asked what is going to be the treatment. So whenever you find class 4 diffuse proliferative, only steroids will not be enough. You need to give azathioprine, mycophenolate, mofetil, and all these other immunosuppressives along with the steroids, if it is class 4. Need super specialty exam. Once more, you will all come for super specialty. Right there. Same story. Questions are same, answers are expected to be better after 3 years PG. You know that famous say, the questions in Viva Voce will be same for PGs and UGs. Only we are expecting different answers. Sometimes UGs will do better. Especially I observed in Apollo, those who cleared USMLE, step 1 in second year, they'll be very sharp. Fat answers they give, right? So, subendothelial immune deposits, wire loop lesions are the characteristic feature of lupus nephritis, is what you need to remember. If you do immunofluorescence, it's called a full house pattern, where you see IgG, IgA, IgM, C3, C1q, everything will be staining positive. And renal biopsy is the gold standard, is what you need to remember. So, how do you know lupus nephritis is in remission or is there any flare-up? You look for the anti-dsDNA. If there is any rise in the titer of that, that is an indicator of the flare-ups and help you to monitor the response to the immunosuppression you are giving. Now, what are the drugs which can lead to lupus? Don't forget the list, doctor. Be ready. Hydralazine, procainamide, isoniazid, methyl dopa, minocycline, quinidine. They're all responsible for drug-induced lupus. What is the antibody in drug-induced lupus? Antihistone antibodies. Mari gadi attention. Right? నేను పొద్దున 5 గంటలకు పెడతాం భజన్ ప్రోగ్రామ్. మీరు లేచి కూర్చొని ఫట్టుమని ఆన్సర్లు చెప్పాలి. More than teaching, let me tell you, the role of the teacher is to do bhajan. Right? I ask questions. You answer competitively in comparison to others. Take the mic. Or we will keep chat. Chat is better because when multiple people are answering. But chat, my problem is you see others answer and then you will also start. It's okay. Much better is quiz, where you unknowingly answer and the results keep coming up. Right? We'll do that. Quinidine is antiarrhythmic, which lead to lupus-like illness. Similarly, chlorpromazine, anti-tuber necrosis factor drugs, they're all the ones. Now, whenever there is a drug-induced lupus, unlike the systemic lupus, erythematosus, two types of lupus, SLE and drug-induced. In drug-induced, two things, renal and central nervous system are spared. They don't involve in drug-induced lupus. The diagnostic clue, antihistone antibody, tomorrow examiner will give you, right? Now, quickly talk about antiphospholipid antibody syndrome. There will be recurrent abortions because antiphospholipids lead to antibodies, antiphospholipid antibodies. They lead to a prothrombotic state that lead to placental vessels, thrombosis, that lead to abortion. So recurrent abortions, deep vein thrombus, development of the stroke, livido reticularis, a net-like pattern of mottled appearance. This is an image-based question. You need to be very sure. Right, doctor? So by tomorrow, 2 o'clock, the NEETPG mock test 12 will become uploaded. Solve that. But tomorrow, we will have discussion of the Wednesday paper, the Thursday paper, which we didn't discuss. Right? So that's the plan. So livido reticularis is the classical feature, and lupus anticoagulant lead to prolonged APTT. Why? To do the APTT test, you need to use the serological method, the same antiphospholipid antibodies as the ones which you see in a patient who has got SLE. That's the reason APTT look prolonged, but prolonged APTT does not mean he has a bleeding diathesis. He has got a thrombotic tendency, not bleeding diathesis. You understand? In SLE, see, once upon a time, in the European society, they found women who are having recurrent abortions are found to have VDRL test positive. They didn't know why they are having VDRL positivity. Because the antiphospholipid antibody which is present in the blood of these SLE women will cause false positive VDRL test. And VDRL is a sign of syphilis. And a high society girl getting blamed for syphilis positivity. So then somebody came up with the thought that no, this is not syphilis, even though VDRL is positive. They're all very naive. Maybe that physician's wife also was antiphospholipid antibody positive, who had who was wrongly mistaken for who is mistaken for wrongly mistaken for a telumedia background. Wrongly mistaken or rightly mistaken kabhi nahi rehta. So mistaken for syphilis maybe. So then they found that, hey, this is not syphilis, real VDRL, it is a false positive VDRL because of the presence of the antiphospholipid antibody. So that the in vitro test of VDRL become positive. Atlane, the in vitro test of APTT become prolonged in vitro. Not really, there is a problem in the intrinsic pathway, in coagulation pathway. The test in vitro become false positive if the blood belongs to somebody who is having antiphospholipid antibodies. Understand? Now, what is the challenge in the clinical practice? A pregnant woman, Geeta, has arrived. She had multiple recurrent abortions, diagnosed to be SLE. Luckily, this time she is pregnant, right? She is having DVT. Because of the pregnancy itself is prothrombotic state. On the top of it, she being a patient of antiphospholipid antibody syndrome, the antiphospholipids will lead to prothrombotic state. In her to treat, you need to give heparin. But heparin is monitored with APTT. But APTT will be false positive because of her antiphospholipid antibodies. Then how will you monitor Geeta? They are the real clinical challenges. Still we give heparin, low molecular weight heparin that does not require monitoring with APTT. We can't give unfractionated heparin, but we can give low molecular weight heparin, Clexane injection. Clear? So that is the brief story, doctor. Antiphospholipid antibody, patients will have anti-cardiolipid antibody that lead to false positive VDRL. What do you mean by catastrophic APS? When multiple organs suffer from thrombosis. There's a DVT, pulmonary embolism, and also there is a stroke altogether. And they have got thrombocytopenia. Still they are a prothrombotic only, not bleeding, even though they have thrombocytopenia. So they are the things that you need to remember about antiphospholipid antibody syndrome. So how do you treat SLE? SLE is very common entity. Even if you're a dermatologist, gynecologist, anybody will come across. Hydroxychloroquine sulfate, HCQS, 200 milligram tablet will be available. It is indicated in all SLE patients. Then we give steroids for rapid anti-inflammatory effect whenever acute flare-up is there. Whenever severe nephritis is there, we have to give cyclophosphamide. Mycophenolate mofetil is an alternative. Azathioprine is a steroid-sparing immunosuppressant. Then belimumab, which is anti-BLYS monoclonal antibody. Whenever there is a refractory SLE, this also will immunosuppress. Remember, this will come in exam. Rituximab, which is anti-CD20 monoclonal antibody, is also given. And we give for arthritis, NSAIDs for symptomatic relief. Their sun protection because they have photosensitivity. And ACE inhibitors, if you give in them, they are renoprotective, decreasing the proteinuria is what we need to remember. So what are the final 10 high yield facts? Fatafat you need to revise for the exam. Anti-Smith antibody, more specific. Anti-DSA DNA antibody. Lupus nephritis. Malar rash will spare the nasolabial folds. It is the non-erosive arthritis. And diffuse proliferative fall under class 4. Wide loop lesions with subendothelial immune complex deposition. Drug-induced antihistone antibody. It's called Liebman-Sachs endocarditis, which is present on both sides of the valve leaflets. And false positive VDRL is due to anti-cardiolipin antibody. So when you go to the exam after 200 questions, where is my SLE? Catch it, throttle its neck. One of these is there. Expect it and attack it. That's how all 1,000 topics you should do, doctor. I leave the literature for you. Now comes the sister of SLE, rheumatoid arthritis. Right? Now, let's talk. ఎప్పుడు ఒక 10-15 పాయింట్స్ రెడీగా ఉండాలి. బతుకమ్మ ఉయ్యాలో రుమటాయిడ్ ఆర్థరైటిస్ లో ఏముంది టపటపా చెప్పాలి. సో దట్స్ హౌ యూ షుడ్ ప్రిపేర్ ఫర్ ఎంట్రన్స్. In rheumatoid arthritis, it is a symmetrical small joint involvement, mainly metacarpophalangeal and proximal interphalangeal, but not distal interphalangeal. Distal interphalangeal is only involved in two. One is in osteoarthritis. Second, gout. Gout, osteoarthritis lo maatrame distal interphalangeal joint is involved. Nowhere else. So, MCP, PIP are affected. Early morning, there is a stiffness for more than 1 hour. Then how do you differentiate from OA? PIP involvement is OA, PIP involvement is SLE. There will be ulnar deviation, swan neck deformity, and rheumatoid nodules are typically associated with the rheumatoid factor positivity, and they are present on the extensor surfaces. Then pannus formation lead to cartilage destruction, and typically it is inflammatory pain, which is worse in the morning. Female predominant condition. Of course, men also get rheumatoid arthritis. A lot of them. In males, prognosis is much more worse. They'll develop more joint deformities. Then cervical spine involvement is a feature. Most of it is appendicular skeleton, limbs. Axial skeleton only involvement of atlantoaxial subluxation is what you need to remember. Which is the first vertebra, second vertebra? Atlas is first vertebra, axis is second vertebra. Okay, good, very good. That's the reason whenever a rheumatoid arthritis patient is being intubated for a elective anesthesia, you need to be watchful of this atlantoaxial subluxation. Forget about your intubation. You may end up in breaking the spinal cord. Anti-CCP is the most specific antibody, favorite MCQ of the examiner. It predicts the erosive disease is what you need to remember. Very good. Aaj check test. Me asal per vettandra naina. Please put your actual name. I will be happy to call you. All abbreviated names, sir. Good. So shortly we will conduct a live online quiz. Be ready. Fatafat you should answer. We'll give you 15 seconds time for you to answer. So that will bring that competitive spirit. So my role is mainly to add a bit of adrenaline, not the myelin sheath. You're already brilliant kids. 2.5 million tried. You are 1 lakh who got it. Of course, some of us got in because of the dad's 1 crore or 65 lakhs of money. That's a different story. It's okay. But you survived medical school, right? Right? All that stupid lectures, which are sleepy PowerPoints and they force attendance on you. Where there is less teaching, more discipline. Remember that. My father never disciplined me. He used to always appreciate extrovert, innovation, new things. Even if you fail exam also, no problem, sonny. Exam is just a game. Come on, let's go. I still have that letter. He wrote a postcard. He wrote in our time in MBBS entrance exam, 50 biology, 50 physics, 50 chemistry. In the first attempt, when I attempted, I got 46 in chemistry out of 50. And 40 in physics out of 50. 7 marks in biology. I used to hate biology. Right? So I got big rank. In those days, 1400 rank. Today, 1400 means they'll put red carpet and invite. So he wrote me a letter. See, Murli, your arrogance saying physics and chemistry are beautiful, though you are destined to become a medical student, you lost the chances with your own hand of not reading biology. This should make a young man like you to get back to the ground and accept the facts of life. Good luck for the next attempt. He used to stay in Lucknow, and I was there in Warangal. So when I read that letter, I felt he didn't say anything that I'm ashamed of you or anything. He told very proudly, just you need to ground yourself from an academic arrogance. Next time I made it to Gandhi Medical College. So what I want to say is some subjects we will have aversion. I don't want to read SPM. I don't want PSM. I don't like all the prolapse of uterus, that lip heart surgery, blah, blah, blah. Yeah, we'll have aversions. But still, we need to have some working knowledge to answer. That's very important, doctor, right? So that's the reason every minute, every day, don't run behind any schedules, because no schedules are possible strictly in the adult life, because our life has so many things. No, daddy want us, mummy want our time, or friends want our time, boyfriend want, girlfriend's roommate want our phone number. What we can do, right? So, but still, whatever the available time, you should study, be contented, be happy, enjoy while reading. Okay, this is the point they will ask. Tomorrow when I see that, I recognize it. Clear? Good. What is rheumatoid factor? It is IgM against IgG. It is the IgG's FC component. There are antibodies against that. What is the type of antibodies? IgM. All the men run behind the girls. M is behind G. That's what you need to remember. Anti-CCP citrulinated peptide is highly specific. ESR is elevated, CRP elevated. And what type of anemia? Anemia of chronic inflammation, which is normocytic, normochromic anemia, is what you need to remember. There will be reactive thrombocytosis. And if you take the synovial fluid, it is of a low viscosity because of the inflammatory cells. Unlike SLE, where you have low C3, C4. In case of the rheumatoid arthritis, C3, C4 are normal. This is the hit point, which you need to get. Only you know this. Then HLA, DR4, there is an association. Ferritin, which is an acute phase reactant, is being elevated, is what we need to remember. Now, what are the extra-articular manifestations? Lung is involved with interstitial lung disease, right? Now, one important thing, we give methotrexate in a patient of rheumatoid arthritis. Methotrexate also can lead to interstitial lung disease. Whether this is due to that or this, we don't know. We have to find it. Similarly, pleural effusion. It is an exudative pleural effusion. That is the reason there is a low glucose. Classically, in rheumatoid arthritis, pleural effusion, pleural fluid will have low glucose. Low glucose in pleural fluid with somebody with arthritis means examiner is asking, rheumatoid arthritis is what he is expecting. Then Sjogren's can be associated with rheumatoid arthritis. So what is Sjogren? Sjogren is lymphocytic destruction of the exocrine glands. What are they? Lacrimal gland, salivary gland. If you do biopsy, you find lymphocytic infiltration and destruction. So there will be drying of the eyes, drying of the mouth is very classical feature. There is an episcleritis where there is a painful red eye. Pericarditis in rheumatoid arthritis can occur. Carpal tunnel syndrome where median nerve compression can occur in rheumatoid arthritis. Rheumatoid nodules are on the extensor surfaces on the pain points. Pressure points. There is a vasculitis because of the rheumatoid arthritis which is long-standing. Then what is Felty's syndrome? Favorite question like that. Felty is rheumatoid arthritis plus splenomegaly plus neutropenia is called Felty's syndrome. Similarly, the chronic inflammation of the rheumatoid arthritis and the anti-inflammatory drug steroid. दोनों बदमाश है, दोनों के वजह से osteoporosis आ सकता. It can be because of either of the two, right? Both the treatment and the condition. So now, what are the 10 points? Hot points for examiner. Earliest X-ray finding in rheumatoid arthritis is soft tissue swelling. There are marginal erosions. The joint spaces, there is a uniform narrowing. There is a periarticular osteopenia, juxta-articular, which is very classical of rheumatoid arthritis. Joint together, ऊपर वाला bone, नीचे वाला bone, दोनों में osteoporosis आता around the joint. Swan neck deformity is the PIP, proximal interphalangeal joint hyperextension and dip flexion. Boutonniere deformity is PIP flexion, opposite, and dip hyperextension. Then ulnar deviation. There can be a bamboo spine which is seen in ankylosing spondylitis, not in rheumatoid arthritis. Don't get confused. There can be a pannus, and the fibrin aggregates in the synovial fluid are called rice bodies, which are seen in case of rheumatoid arthritis is what we need to remember. अच्छा बच्चों, rheumatoid arthritis का treatment क्या होता है? Methotrexate, which is a folate antagonist, is the first line demand. Hydroxychloroquine is an immunomodulator, not suppressive. But long-term hydroxychloroquine can lead to bullseye maculopathy in the retina. Sulfasalazine is the safe anti-inflammatory in pregnant women with rheumatoid arthritis. Leflunomide is a pyrimidine synthesis inhibitor. Why we use pyrimidine synthesis inhibitor? Inflammatory cells. They try to produce their children, grandchildren, and attack. So we want to stop their produce. So you stop the DNA. To stop the DNA, you give pyrimidine synthesis inhibitor, which will stop the inflammatory cells getting recruited. Just like you stop the black money. आज की रात से 5,000 काम नहीं करेगा. So terrorists who are getting the black money served to them, they stop. Right? So like that, leflunomide is inhibiting the pyrimidine and preventing the multiplication of the inflammatory cells. But leflunomide is notorious for hepatotoxicity. We use TNF-alpha inhibitors, which are immunosuppressive of cell-mediated immunity. Cell-mediated immunity is not there, a latent TB can flare up. That's the reason before you give a TNF-alpha inhibitor, you need to rule out whether the patient is having any TB. Rituximab, anti-CD20 monoclonal antibody, typically lead to B cell depletion. B cells have CD20. Tocilizumab is an interleukin-6 inhibitor whenever severe rheumatoid arthritis therapy is required. Then we use JAK inhibitors which basically inhibit the signal transduction receptor JAK. They're all used in rheumatoid arthritis to suppress the immunity. Herpes zoster can wake up the moment you immunosuppress with JAK inhibitor. For symptomatic relief, we use the NSAIDs, but they're only symptomatic. They do not prevent the progression, is what we need to remember. So do we give prednisolone? Yes, sir. It is a bridge therapy. Whenever acute flare-up of rheumatoid arthritis is there, to control for a while, you give steroid, not for long-term management. This is the treatment of rheumatoid arthritis, state of art. People do MBBS, MD, DM, almost 15 years of their 75-year life. Kitna? 75 by 15, 5, 1 by 5. 20% of life. They spend ultimately to give these 4 or 5 medicines. So, don't think my friends got seat, I am not getting seat. Everybody become pregnant, no problem. Only thing is, some early, some late, some after recurrent abortions, right? Life is, somebody get married early and divorce early. So it really doesn't matter. It is all customized life. Most important, doctor, first health. Second, personal achievement. Are you able to walk with your daddy? Are you able to sit with your mom? Right? Pressing her feet and able to talk to her. Are you able to sit with your younger brother and able to do some study with him? Are you able to hang out with your friends and have had a beer or not? I mean, not necessarily beer, cool drink. Huh? So personal life is most important. Health, personal life. Then comes professional, academic achievement. No big deal. Life is short. Right? So that's very important. Next, doctor, what are the differentials to rheumatoid arthritis? Osteoarthritis, but it is non-inflammatory. Dip involvement is there. SLE arthritis, it is ANA positive and non-erosive, unlike rheumatoid arthritis. Psoriatic arthritis, typically it is the dip involvement with nail pitting, penicillin cup deformity. They're all the classical features. Ankylosing spondylitis, it is HLA B27 positive. It is a sacroiliitis, lower back pain as a presentation. And mainly, it is the axial skeleton, not the appendicular skeleton, which is involved in ankylosing spondylitis. Reactive arthritis. Typically, there will be a history of urethritis or gastroenteritis. Following that, the patient will have uveitis, arthritis, after either urethritis or gastroenteritis. He can't be urethritis. He can't see uveitis. He can't climb arthritis. He can't see, he can't pee, he can't climb. Is reactive arthritis. Clear, doctor? So, that's how you differentiate. Then Felties is rheumatoid arthritis plus splenomegaly plus neutropenia, which is a severe most form. Kaplan syndrome means what? Rheumatoid arthritis plus pneumoconiasis in coal workers is called Kaplan. What is Still's disease? Still is juvenile rheumatoid arthritis. Here you have a very high ferritin. Salmon pink, evanescent rash. Fever, high ferritin. Juvenile rheumatoid arthritis. Then septic arthritis. It is the acute monoarthritis. So any young individual, 34, 35, came to you with the acute monoarticular arthritis, monoarticular arthritis of the knee, what is the question you will ask? क्यों भाई Bangkok गए क्या? Or Singapore gaye kya? If you go to Singapore, there'll be one street. Oh, come with me, dear. Please come with me. There will be somebody who will be, it is quite open. It is legalized in the country. Right? I'll give a happy ending to you. Please come. They will be pulling. So this 34-year-old man went for a happy ending because his wife is pregnant and went to Maike. And he came back to your hospital saying, coming with monoarticular arthritis, which is typically gonococcal arthritis. So that is the reason always any acute monoarthritis in a young individual, when the examiner gives a question, you should immediately check whether he is talking about gonococcal arthritis. Septic arthritis is what you need to remember. So that is the story, doctor. Now you are expert in rheumatoid arthritis. There are another 30 points. Same things, rapidly revised. So in the boot camp, totally 1,000 topics. Each topic, each subject may top 60 topics. Each topic will have 8 images like this. That will revise everything that you need to know. Working knowledge for facing the question paper. And NEETPG examiners' patterns don't go beyond this. So take this seriously. All illustrations like Amar Chitra Kada for you to do the revision, doctor. Right? So, good to see 14 online classmates. We are becoming popular. So tomorrow we will plan 12 o'clock for test discussion. Last Thursday's test. Right? Now comes Henoch-Conlin's purpura. It is a IgA vasculitis. It is an IgA mediated small vessel vasculitis, the most common vasculitis in children. There's a deposition of the IgA immunocomplex in the skin and the kidney. After the upper respiratory tract infection, typically with streptococcus, there is a development of multiple vasculitic purpurae, typically on the buttocks, thighs, back of the thighs. They are the classical location. Peak age is 3 to 10 years with a male predominance, and it is common in the winter or spring. It is the capillaries, venules which are involved. And what is the histological hallmark of Henoch-Conlin purpura? Leukocytoclastic vasculitis. Then what is the classical tetrad? Purpura, arthritis, abdominal pain, and renal disease. Why abdominal pain? Vasculitis involves the mesenteric vessels. Because the mesenteric vasculitis, there is an ischemia to the bowel, leading to the abdominal pain, the classic tetrad, don't forget. A child presenting with purpura, arthritis, with abdominal pain, and there is also hematuria. Still, you are thinking, looking into sky and thinking, what can this be? Oh, no, sir. Already 150,000 people might have answered it as Henoch-Conlin purpura. Utta cheap chitka question hai. So you must be prepared for common things examiner asks. Clear? If you felt exam paper hard, your preparation was easy. Found paper easy, your preparation was tough. Which one do you want? Easy way or hard way? Now, doctor, platelet count. It is a purpura caused by vasculitis, not thrombocytopenia. It is a palpable purpura. Palpable purpurae are vasculitic. Impalpable blanching purpurae are extended petechiae, which are due to thrombocytopenia. Non-palpable purpurae are thrombocytopenia. Palpable purpurae are vasculitic purpurae. And this is a pauci-immune type of glomerulonephritis. That's the reason the complement levels are normal. classically in Henoch-Collins purpura when the kidney is involved. So that leukocytoclastic vasculitis, recognizing on the histopathology image-based MCQ, you need to be doubly sure about, doctor. Palpable purpurae on the buttocks, legs is commonly affected. It is non-thrombocytopenic. Typically, there is a lower limb predominance in the dependent areas. It is symmetrical with the crops of lesions. There is an arthritis, which is a migratory large joint arthritis involving the knees and ankles in Henoch-Collins purpura. There can be arthralgia, where pain without swelling, only pain, algia can be there, which is self-limiting. Commonly, there is an edema on the scalp, hand, feet, common in children. There can even be scrotal edema with that abdominal pain, may be mistaken for torsion, right? So scrotal edema. And there is no permanent joint in spite of arthritis, unlike in rheumatoid arthritis, where you get all swan neck and all that. And recurrence is very important. So that is the reason most common cause of the recurrent benign hematuria. Recurrent benign hematuria is IgA nephropathy. See, it's a two end of the spectrum. IgA nephropathy, Henoch-Collins purpura. Clear? Then what is this type of hematuria called? Synpharyngitic hematuria. There is a pharyngitis, sore throat. Unlike in post-streptococcal glomerulonephritis, where 3 to 4 weeks ke baad, you get hematuria after pharyngitis. Here, it is 3 to 4 days after sore throat, sometimes 1 or 2 days, the kid gets hematuria. Whereas in PSGN, post-streptococcal glomerulonephritis, 3 to 4 weeks later. Then post-streptococcal glomerulonephritis is immune complex mediated. C3, C4 are low there. But here C3, C4 are normal. Whereas PSGN, hypercomplementemia. There is a close differential. There's a colicky abdominal pain because of the mesenteric vasculitis. GI bleeding can be there. Melena can be presentation. Sometimes it can lead to ileocolic intussusception. One part of the bowel walks into another. There can be a vomiting, acute abdomen, bowel ischemia due to the vasculitis, which is a surgical emergency. Rarely there can be acute pancreatitis. There can be hematemesis. There can be bowel perforation. They're all the complications ultimately. So what is this sign called? Whenever there is any intussusception, intussusceptum inside the sussupiens is called downward sign or target sign. When you do ultrasound, you see one part of the bowel surrounded by the other part of the bowel. This is a radiology question, image based. So the most common renal finding is hematuria. Microscopic more than gross hematuria. Then proteinuria, nephritic picture, even nephrotic syndrome can be there in Henoch-Collins. And what type of glomerulonephritis? Rapidly progressive glomerulonephritis, crescentic glomerulonephritis. So what are crescents in the Bowman's capsule? You have a visceral and parietal epithelium. It is a parietal epithelial proliferation, which is called crescent, that will obliterate the Bowman's capsule space and lead to rapidly progressive glomerulonephritis. There can be a mesangial IgA deposition. Renal prognosis is usually good in children and very uncommon to get a proper renal failure. So I'll leave the literature for you, doctor. Remaining thing is all game. Okay? So of course, we give supportive care for arthralgia, NSAIDs. We give steroids to abdominal and joint symptoms. We give IV steroids for severe nephritis. We give immunosuppressants like cyclophosphamide sometimes, ACE inhibitors to decrease proteinuria, rarely dialysis. For intussusception, we do surgery. This is the story of IgA nephropathy, Heinrich-Schönlein purpura. Clear? So, doctor, the next is polyarthritis nodosa. Every NEETPG you go, they're all classical topics. We know I bring a pair, Akshara. Ayyo. No problem. Ippudu vinu. Right? It doesn't matter. In the love and war, better late than never. Right? So, doctor, rotavirus also intussusception. Very good. We have got a Aj check test. Up to date. That's good. So, yeah. Polyarthritis nodosa. Rheumatology sangat చూసిపోదాం ఇంటికి. ఉన్నదా పెట్రోల్? Okay. So, yeah. Always vasculitis. Small size, medium size, large vessel vasculitis. Classification. You should be sure. So, polyarthritis nodosa is a medium vessel necrotizing vasculitis. There is another entity called microscopic polyangiitis. మనకి ఇదే తెలియదంటే అదొకటి. పాన్ ఒకటి, ఎంపీఏ. డిఫరెన్స్ ఏంటండి అంటే polyarthritis nodosa involve the kidney but not the lungs. Microscopic polyangiitis involve both the kidney and lungs. You remember? But yeah. So it is a small muscular arteries where there is a transmural inflammation. And if you take the vessel wall, there is a fibrinoid necrosis that will weaken the wall of the vessel, that lead to aneurysmal dilatation. Right? So it looked like polyarterial nodes, polyarthritis nodosa. Right? Then usually this is ANCA negative. There is another big brother called Wegener's granulomatosis, which is also small vessel, medium-sized vessel vasculitis like this. But they're ANCA positive, but here ANCA negative. They differentiate it from the Wegener. Then 30% of the patients of polyarthritis nodosa have hepatitis B seropositivity. Favorite MCQ. Winner ఎప్పుడైనా పాయింట్ polyarthritis nodosa అంటే HBV seropositivity 30% is the sure shot question. Then there is a renal vessel vasculitis. No glomerulonephritis in polyarthritis nodosa. Then typically lungs are not involved in PAN but involved in microscopic polyangiitis. There is a renal mesenteric blood vessels. There is an aneurysm, microaneurysms form on the vessel wall because of the weakening due to transmural inflammation, due to fibrinoid necrosis. Typically, middle-aged adult male is a typical patient. So don't forget favorite question. HbSAg positivity is the classical feature which you need to remember. So typically, the patient presents with fever, weight loss. From fever, weight loss to the diagnosis of polyarthritis nodosa is a journey. पढ़ने में मजा रहता, सचमुच पेशेंट में डायग्नोज करना बोले तो मुश्किल है, करे तो भी गुड न्यूज नहीं है. If it's a simple fever, fine. Most common initial presentation. Then there is a livido reticularis, painful nodules with ulcers. is very common. So where else did you find livedo reticularis? SLE. Very good. And there is a mononeuritis multiplex. One nerve here, one nerve there because of vasculitis. Put it in a neuropathy that went to Tirupati, or still you remember? Good, good. ఈ నోట్స్ ఉందా మీ దగ్గర? ఓ బాబు సురేష్, మా అక్షరార్థైన మీరు అడగలే మరి? అడగందే సురేష్ అయినా పెట్టలేడు. Please, there is a beautiful boot camp notes PDF. He will activate you free for Akshara. So, I will, after you become gynecologist, I will send 5 patients as an exchange for 5,000 NEETPG patterns notes. You do free delivery to them. మళ్ళీ ₹1,00,000 తీసుకుంటారు ఆబ్స్టిట్యూషన్స్. 1 लाख लेते हैं ऑब्स्टिट्यूशंस डिलीवरी के लिए, आप 5 लाख फ्री करना, 5 डिलीवरीज. प्रॉमिस? ओके, आई रिमेंबर. So, mononeuritis multiplex. I'm not just joking. There are n number of my students who were sitting like you once. Today they are top consultants. Whenever patient can't afford, I send them in hundreds to be taken care free as a Guru Dakshina, even though they paid fee. So, foot drop is very common due to the mononeuritis multiplex. There can be hypertension, renal ischemia, and mesenteric ischemia, and coronary arteritis with MI. Risk is there in polyarteritis nodosa. And muscles can involve in myalgia, tender muscles can be there. There can be a testicular pain, which is very, very characteristic clue to say it is polyarteritis nodosa. Once more due to vasculitis and ischemia. Then in the CNS, there is a stroke, seizures, CNS vasculitis. Then retinal vasculitis, visual symptoms are possible. They're all the features of polyarteritis nodosa. Poly, multiple arteries, which became nodular aneurysm. ESR is elevated, HbA1c is positive, ANCA is negative, elevated creatinine with ischemic nephropathy, and angiography will show beaded appearance due to these microaneurysms. Necrotizing arthritis with fibrinoid necrosis is classical, and you do CT angiography to find those mesenteric aneurysms is what we need to ultimately remember. So, if you look at the complement levels, they are usually low normal, is what we need to remember. That normal, but in the normal, upper and lower limit, no, towards lower norm. So, very important, doctor. This one infographic will fill your score. Pulmonary capillaritis is a feature of microscopic polyangiitis, but pan will spare the lungs. Granulomatosis with polyangiitis, other name for vaginous granulomatosis ka dusra naam. Mundu vaginate teliyadu, but dani other name kuda telusukovali. Sianca positive. Every vaginal. Whereas pan is ANCA negative. Then eosinophilic granulomatosis, right? With polyangiitis, the other name for Churg-Strauss syndrome. In this, you get asthma plus eosinophilia. Close differential. Takayasu is a large vessel disease. Pan is a medium vessel vasculitis. Kawasaki is a pediatric vasculitis with coronary vessel aneurysms, whereas pan is a adult vasculitis also can lead to coronary vessel aneurysm. Burgers, there are smokers with distal ischemia, whereas PAN is an ischemia in any vascular territory. SLE is ANA, dsDNA positive, PAN doesn't have. In cryoglobulinemia, which also lead to vasculitis, there is an association with HCV, whereas polyarteritis nodosa is HBV. IgA vasculitis, there is IgA deposition. PAN is non-IgA. So that is how other vasculitis are differentiated. So NEETPG is not for 200. 199, one question is from vasculitis. Guarantee, seat guarantee topic. So how do you treat, doctor? Corticosteroid, cyclophosphamide. Then, if there is HBV, antiviral therapy, plasma exchange, azathioprine, methotrexate, control the BP, manage the pain, give rituximab is considered to be the management. So I leave the literature for you, doctor. Right? Now, next topic is gout. Quickly, 10-20 points on gout. Either overproduction of uric acid or under excretion of the uric acid is equal to gout. Crystal is a monosodium urate, which is needle-shaped crystal, strongly negative birefringence, yellow when parallel, right? Yellow color in when parallel, strong negative birefringence. It is the first metatarsophalangeal joint which is involved. Big toe, swollen podagra, it is called. So when a patient walks into your clinic, excruciating pain because of the first metacarpophalangeal joint, what will you do? Open the mouth, put an indomethacin, ibuprofen, mainly ibuprofen, NSI, suddenly pain reliefs. He will thank you and he will bring the whole street of his friends. You are the best doctor. So pray God that let my gout patient come today only. I opened the clinic. Sometimes luck should be there. So any alcohol, trauma, surgery, fasting can be the triggers of an acute attack. And if you go to any area which is cooler temperature also, the crystals can precipitate. Gout crystal, urate crystals. So the key mediator is interleukin-1. It forms what is called NLRP3 inflammasome. Inflammasome is the underlying pathophysiological mediator. So we give colchicine, which is anti-inflammatory, to stop this inflammasome from forming. Now, conditions like chronic kidney disease, leukemia, psoriasis, where the cell turnover is high. From where is uric acid formed, Dr. Uric acid is the end product of purine metabolism. Purines are part of DNA. When the cell's turnover is increased or cell destruction is increased, more purine is released. When a cell is destroyed, DNA is released. That purine converts into uric acid. That's the reason. Psoriasis, leukemia, CKD, there are secondary causes. Lesch-Nyhan syndrome. You know what, parent? Lesch-Nyhan syndrome. Hey. Neeta will commit suicide if you happen to tell correct answer. she'll get heart attack. So, yeah. HGPRT, hypoxanthine guanine phosphoribosyl transferase deficiency. Lescheri-Hahn syndrome will also have hyperuricemia. Then any red meat, seafood, fructose drinks, the diet worsens the gout. Red meat, seafood, fructose. One of my friends went to China. By the time he came in the aeroplane only, he has got gout. Otherwise, very stable man. Up to 50 years, nothing happened. One China visit brought it. So, podagra is that painful, swollen great toe. Is the most common presentation. It is typically the nocturnal pain, really very excruciating pain. And ear pinna is a common site for the tophi to deposit. And chronic gout lead to polyarticular deforming arthropathy, it is called. It mimics the late stages of the rheumatoid arthritis. The skin over the joint will be red, shiny, tender, can resemble like a cellulitis. And there can be a fever in acute flare-up. That's the reason a lot of times there is a confusion whether it is a septic arthritis or gouty arthritis. Both will lead to overlying skin. Right, doc? So, 10 points about the gout, you need to be very sure. Most important is treatment. One question will come. They give NSAIDs, colchicine, allopurinol, febuxostat, probenecid, pegloticase, steroids, rusburicase, aspirin, low-dose, and losartan. Chalo. Quick mechanism. NSAIDs inhibit prostaglandins. Indomethacin is a classical drug that you use to treat the gout. Colchicine inhibits the microtubules, but it can lead to diarrhea as a side effect. Allopurinol is a xanthine oxidase inhibitor, also febuxostat. It is the first line urate lowering drug. If it is not tolerated, you can give febuxostat. Probenecid is a uricosuric drug. High uric acid in the blood, it will go into urine. But that can precipitate urate stones. So that is a known side effect of probenecid. Pegloticase converts uric acid, a toxic product, into non-toxic allantoin, which is used in refractory gout. Steroids are anti-inflammatory. Rusburicase is a recombinant form of uricase. There is an entity called tumor lysis syndrome. Where do you get that? In acute promyelocytic leukemia, if you happen to use chemotherapy, it will rapidly lyse the cells, malignant cells, and release that DNA, purines, and lead to hyperuricemia. In such people, tumor lysis syndrome, when hyperuricemia is there, we use rusburicase, which is recombinant uricase. In low doses, aspirin reduces the uric acid excretion, right? Reduces. So if a patient who had gout is taking ecosprin 75 milligrams for his heart, that can precipitate gout. Sometimes a patient otherwise don't have gout and you give aspirin and he may end up in gout. ये सब होता है practice में. Losartan is also a uricosuric antihypertensive. That's the reason it's a preferred BP drug in gout, is what you need to remember. All right, doc. So, what are the precipitating factors for gout? Lescheri-Hahn syndrome, HGPRT deficiency, Kelly-Siegmiller syndrome, which is a partial HGPRT. Then tumor lysis syndrome, psoriasis, lead nephropathy. Even in lead poisoning also, there is a development of gout. That's called saturnine gout. Then pseudo-gout is calcium pyrophosphate crystals. Septic arthritis is fever plus hot swollen joint. You must rule out before considering gout. Metabolic syndrome, those who have obesity, hyperglycemia, hypertension, dyslipidemia, they are highly vulnerable to develop the gout. Alcoholism, beer, no beer. Beer predisposes to increased uric acid production. Now, radiology, favorite questions are there in gout. How are those erosions in gout? They are called rat bite erosion. Elka korikina, emuka mukkalu. So, rat bite erosion, juxta-articular punched out lesions is the classical X-ray finding in gout. Then there will be marginal bony projections. Marginal bony projections, that's called Martel sign. Then soft tissue tophi. Until late, joint space is preserved. Urate stones are radiolucent. You can't catch them in X-ray. They are typically envelope-shaped hexagonal crystals or urate crystals. And there are few things that you need to remember. That's all is the story, Doctor. Gout ka bell ho gaya. Ting, ting, ting. Right? Now, let's give 5-minute voice break. 1:20, 1:11, 1 hour 11 minutes. Typically, one system should be over in 2 hours. That's a goal. ఇంకెన్ని టాపిక్లు ఉన్నాయి చూడండి రొమటాలజీలో. So, welcome back to the session, Doctor. Sarcoidosis. It is a multi-system granulomatous disease. It is granulomatous. TB is granulomatous. But TB is caseating granuloma, whereas sarcoidosis is a non-caseating granuloma, the differentiator. Common between 20 to 40. There will be a bilateral hilar lymphadenopathy. They are called potato nodes. Big nodes, bilateral hilar lymphadenopathy. They present with fever, weight loss, fatigue. There can be paniculitis, inflammation of the subcutaneous fat, which is called erythema nodosa, which is classical. In the eye, it can lead to painful red eye because of the uveitis. There can be parotid involvement in sarcoidosis, where that is called Herford syndrome. There can be a facial nerve palsy, especially bilateral facial nerve palsy of element type is common in sarcoidosis. There is a hypercalcemia because it is inflammation. The macrophages release vitamin D-like substance that lead to hypercalcemia. So a lot of times, which is the hypercalcemia treated by giving steroids? Hypercalcemia in sarcoidosis. Because why there is hypercalcemia in sarcoidosis? All that excess inflammatory cells, they are releasing vitamin D-like substance. So suppress the inflammation, suppress the vitamin D, suppress the hypercalcemia. Favorite MCQ. Which hypercalcemia we use steroids to treat? Then there is a asteroid bodies where there is a formation of the granuloma. Now we divide sarcoidosis into stage 0, 1, 2, 3, and 4. 1 is normal chest X-ray. 2 bilateral hilar lymphadenopathy. 2 is, 0, 1, 2. 2 is with pulmonary infiltrates. 3 infiltrates without BHL. And stage 4 is pulmonary fibrosis. If you do HRCT, there is a classical thing. The sarcoid lesions will have a perilymphatic swelling when you do HRCT, more in the upper lobe. So what is meant by Garland's triad? Bilateral hilar lymphadenopathy plus right paratracheal lymph nodes. Bilateral hilar plus right paratracheal. These things. This is one bronchus, bilateral hilar plus paratracheal. Garland's triad. Then if you do gallium scanning, the lacrimal and parotid will pick up. And it looks like a panda, Kung Fu panda. That's called panda sign. Lambda sign. Bilateral hilar lymphadenopathy, typically on the gallium scan, look like a lambda. Right? Lambda sign. And if you do pulmonary function tests, you find a restrictive lung disease, decreased diffusion of the carbon monoxide is very classical. And sarcoidosis is the greatest mimicker. Rheumatologists think this is our disease. Pulmonologists think, oh, this is our disease, interstitial lung disease. Right? Then there is a liver involvement, brain involvement, skin involvement, greatest mimicker. So what is the classical feature? Non-caseating granuloma. Langerhans giant cells, asteroid bodies, stellate inclusions, laminated calcifications, which are called the Schauman's bodies. Angiotensin converting enzyme levels are elevated, calcium is increased, ESR elevated, and if you do bronchoalveolar lavage in that fluid, CD4 by CD8 ratio is increased more than 3.5 is equal to sarcoidosis. In spite of all these granulomas, it is not TB, hence tuberculin test is negative. Queen test is an intradermal sarcoid tissue reaction, but no more used historically. Queen. Okay. Now, what are the extrapulmonary sarcoidosis? In the eye, it leads to uveitis. In the heart, it leads to restrictive cardiomyopathy, neurosarcoidosis, facial palsy, nephrocalcinosis due to hypercalcemia. It can lead to hepatomegaly, splenomegaly, lytic lesions in the phalanges that is called lace-like appearance. Lace-like appearance in the typical bone lesions. And typically in the skin, it leads to red lesions, which are called lupus pernio. These are all image-based MCQs. In the muscle, it can lead to myopathy. There can be a pituitary involvement leading to the diabetes insipidus due to ADH deficiency and non-production of the ADH. That is sarcoid. So what is Lofgren syndrome? Erythema nodosum plus arthritis plus bilateral hilar lymphadenopathy is Lofgren. Hereford, uveitis plus parotid swelling plus fever plus facial palsy is Hereford. Blau syndrome. Familial granulomatosis disease with pediatric onset is Blau. And how to differentiate from TB? Caseating granulomas and TB, non-caseating in sarcoid. Occupational exposure, beryllium exposure. It also berilliosis mimics sarcoidosis. Hodgkin's lymphoma, because the mediastinal lymphadenopathy. But Reed-Steinberg cells are found in Hodgkin's. Hypersensitivity pneumonitis can lead to diffuse interstitial disease, which is a differential. Similarly, granulomatosis with polyangiitis, which is Wegener's granulomatosis. But their Sianka positivity will be there. And fungal infections like histoplasmosis can mimic the pulmonary findings in sarcoidosis. They also form granulomas. That is a differential. If it is silicosis, there you find eggshell calcification of the hilar lymph nodes, which points to silicosis but not sarcoidosis. So how do you treat? Observation, stage 1. A lot of times it will resolve by itself. First line therapy is corticosteroid. You can give methotrexate, azathioprine, hydroxychloroquine, infliximab, oxygen therapy, lung transplant. Stage 1 has the best prognosis. Right? But if there is any cardiac sarcoid manifestation, or if there is a neurosarcoidosis, it has got a poor prognosis. I leave the literature to you. All right, now. So you need to revise it. Next time, if I ask, where do you find bilateral lower motor neuron type of facial palsy? Sarcoidosis. Where do you find potato nodes with bilateral hilar lymphadenopathy? Sarcoidosis. TB versus sarcoidosis, non-granulomatous sarcoidosis, granulomatous. Non-caseating granuloma is sarcoidosis. Caseating is TB. Here, fourth. That's good. Bhajan karna. Go to exam, expect sarcoidosis, hit it. Now, doctor. Next. Granulomatosis with polyangiitis, which is also called Wegener's disease. You need to be doubly sure about. Right now. There's the upper respiratory involvement with chronic sinusitis, epistaxis. Lower respiratory involvement with hemoptysis and nodules in the lung, renal involvement with a rapidly progressive glomerulonephritis. So, due to the sinusitis, he will go to ENT surgeon. Due to hemoptysis, he will go to pulmonologist. Due to renal involvement, to the nephrologist. Who will make diagnosis? Physician. MD, general medicine, is an emperor. Because nephrologists forgot ENT long ago. So now, nasal septal destruction will be there. That lead to vaginal slough, saddle nose deformity. There can be involvement of the ear leading to otitis media, leading to conductive loss. There is an eye involvement with sternitis and episcleritis. And there can be palpable purpurae because of the leukocytoclastic vasculitis even in vagina. And there can be migratory polyarthralgia, constitutional symptoms. There can be neuropathy due to mononeuritis multiplex, like any other vasculitis. So what is important? Serology. Cyanca, which is an antibody that is against PR3, proteinase 3, is cyanca. Pianca is anti-myeloperoxidase. MPO is pianca. Right? There are necrotizing granulomas in vaginous granulomatosis because the necrosis in the lung, necrosis in the upper respiratory tract. There is development of upper respiratory, lower respiratory, and renal involvement. If you do renal biopsy, you find the Bowman's capsules parietal layer hyperplastic, leading to crescent formation, which is posse-immune, where C3, C4 are normal. So if you do immunofluorescence in vagina, it is posse-immune. Minimal or no immune deposits. ESR is elevated, CBP will show normocytic, normochromic anemia. There will be RBC casts in the urine. And if you do the bronchoalveolar lavage because of that hemoptysis, there will be hemosiderin-laden macrophages with diffuse alveolar hemorrhage in vagina. And gold standard to diagnosis is lung biopsy, nasal tissue biopsy, where you can demonstrate the necrotizing granulomas of vagina. So, what are the lung manifestations? Chronic sinusitis, nasal crusting, subglottic stenosis, lung nodules, diffuse alveolar hemorrhage, pleuritic chest pain. There can be tracheobronchial ulceration. There can be cavitary lesions, pulmonary infiltrates, dyspnea. All these are the presentation. Now comes the differentials. Microscopic polyangiitis has no granulomas. Eosinophilic granulomatosis with polyangiitis is the name for the Churg-Strauss disease. But there you have eosinophilia with asthma, even though that is also vasculitis. Good pasture is there is a hematuria and pulmonary alveolar hemorrhages, just like vagina. But there you have anti-glomerular basement membrane antibodies. The closest mimicker is TB. I still remember when I was in first year MD, that guy was a Usmania Medical College intern. His mother was brought. Those days, Nizam's Institute of Medical Sciences is a topmost center for rheumatology when I was in MD, even today. So, his mother was treated by at least half a dozen ENT surgeons. Then they thought high ESR is there. She developed hemoptysis. Hence, probably she is having TB, they thought. They started on anti-tubercular therapy. And anti-tubercular therapy led to development of liver injury, SUOD, SGPD elevated. Then she was brought to NIMS. So, but when we did a close analytics and then did C-ANCA, which turned out to be positive, started on simple immunosuppression, she is already off the TB medicines. So, TB is the greatest mimicker of Veterinary. Sarcoidosis, but there are non-caseating granulomas. Cocaine abuse can lead to vasculitis with vasospasm with necrotic lesions, but it is not ANCA positive. SLE can lead to vasculitis, but their dsDNA NA positive. Like that, you need to rule out. Okay? So how do you treat, doctor? We give high-dose steroids, cyclophosphamide, rituximab, methotrexate, azathioprine, plasma exchange. And those who are on cyclophosphamide, that immunosuppression, like HIV, lead to immunosuppression, can lead to pneumocystis carinii. So we need to give trimethoprim, sulfamethoxazole prophylaxis in the people receiving cyclophosphamide therapy. We need to do dialysis. So that is the important thing you need to remember. I leave the literature for you, doctor. Now comes systemic sclerosis. Can the online students can punch? Is the voice loud and clear for all of you, doctor? Yeah, please punch. Can you hear? So tomorrow 12 o'clock, don't miss last Thursday full-scale grand test paper. We will take for discussion. Systemic sclerosis. You should see on Google Images, systemic sclerosis. You'll find like atlas, all possible images. Then you start the topic. If you still want, go to YouTube and say, show me a systemic sclerosis patient. There are n number of systemic sclerosis patients. देखिए यहाँ पूरा शाइनी हो गया है, मुझे पूरा चमड़ा को प्रॉब्लम आ गया, हमारा डॉक्टर साहब बहुत अच्छा ट्रीटमेंट किया. Today, learning is so easy if you want. Right? You don't need a teacher or a video app which sells you plans. Not required. Okay, doctor. Now, autoimmune fibrosis with vasculopathy with excessive collagen deposition defines the core pathology of systemic sclerosis. There's an endothelial injury, Raynaud's phenomena before fibrosis. There is a widespread involvement of the skin with a rapid visceral disease. Lung is involved, liver is involved, kidneys are involved in diffuse systemic sclerosis. Other type is called limited cutaneous systemic sclerosis, which is limited mainly to skin. But there you get what is called crest syndrome. Calcinosis, Raynaud's phenomena, esophageal dysmotility with sclerodactyly and telangiectasia is called crest syndrome. Anti-centromere antibody is typically positive in limited scleroderma, and typically pulmonary hypertension is the major cause of the morbidity in systemic sclerosis. Then anti-SCL70, which is anti-topoisomerase 1 antibody, is typically positive, typically strongly associated with the interstitial lung disease that develops in systemic sclerosis. Anti-RNA polymerase 3 antibody, if it is positive, then there will be a severe renal crisis. they progress into severe renal crisis. So fundamentally, the problem is fibroblasts get hyperactivated, and that leads to excessive collagen production, leading to the development of the fibrosis. There is a vascular dysfunction with the intimal proliferation. And the moment intima is proliferating, the vessels become narrowed, and that leads to digital ischemia. It is female predominant in the middle age, is what we need to remember. So summarize, doctor. Sclerodactyly, tight, shiny fingers, puffy fingers, mask-like faces with tight facial skin, microsomia. Because of that fibrosis, there is a puckering of the mouth, difficulty, small mouth opening. Then skin will get a typical patchy depigmentation that give salt and pepper appearance of the skin. Each of these real photos you will get in Google. Then there is a telangiectasia, digital ulcers, calcinosis cutis. If you take a radiograph, you can be able to appreciate calcium deposits on a plain X-ray underneath the skin. And the tendon will undergo friction rub. Diffuse disease ka marker kya hai? If you move the skin, you can feel the friction between the skin and the underlying tendon. That's the point. So, doctor, this is the main thing. I leave the literature for you. So, there will be esophageal dysmotility, gastroesophageal reflux disease, Barrett's esophagus, and that bowel whose wall got fibrous. There will be growth of organisms leading to the development of malabsorption. There can be wide mouth diverticula that can develop in the gut. There can be fecal incontinence with the internal sphincter undergoing fibrosis. There can be scleroderma, renal crisis. And if you look at the blood vessel, there is a hyperplastic onion skin arteriolar proliferation and elevated renin levels. That's the reason, because the renal ischemia. You need to treat with ACE inhibitors, which are very good to prevent renal stenosis. There can be hypothyroidism because of the thyroiditis, which is also autoimmune, can be associated with scleroderma, is what we need to remember. So I leave the remaining things in literature, doctor. Okay, we give calcium channel blockers for the Raynaud phenomena, ACE inhibitors for the renal crisis. For the interstitial lung disease, we give mycophenolate mofetil, and we give cyclophosphamide to treat the lung disease. And we give bosentan, which is the endothelin receptor antagonist, right, which lead to delaying of the progression. And we give proton pump inhibitors for the GERD. And we give sildenafil to improve the vasodilatation and symptoms. Then stem cell transplantation will improve, right? And that gangrene may require amputation. Ultimately, death is decided by pulmonary fibrosis, where they develop oxygen dependence. Even if they walk to the bathroom also, oxygen desaturates to 70% and they die. That's what we need to remember. Okay, doc? So I leave the literature, 8 slides for each. 8 times I am trying to remind you. Hey, Makshara? Right? So, you remind me of my second kid, Abhinav. You are November 7th, he is November 5th. Very sincere student. But within 1 hour, his face become loaded. I'll say, okay, let's go out and have a cup of coffee in a Starbucks. So we come back and study. This is a good idea. Suddenly his face brightens. సో సమ్ కిడ్స్ ఆర్ ఓవర్లోడెడ్, కాగ్నిటివ్ ఓవర్లోడెడ్. అంతే కదా, ఇదంతా ఈ దరిద్రం నెత్తికేసి రుద్దుకోవాలి. అవసరమా? ఫర్ ఎగ్జామ్ వి నీడ్ టు. గుడ్. గుడ్ టు సీ శ్రావణి. అవును, ఏమై మీ శ్రావణి, మీ దోస్తు శ్రావణినా? శ్రావ్య. శ్రావ్య రాలే? Tell Professor Dr. Murli taking attendance. Now, vasculitis is a beautiful topic on which one question comes. We finish vasculitis and go home. Granulomatosis with polyangiitis is vaginous, where you have Sianka, saddle nose deformity. Microscopic polyangiitis has got Pianka, which presents with pulmonary and renal syndrome. Eosinophilic granulomatosis with polyangiitis is Church-Strauss, where it presents with asthma. In ulcerative colitis also, Pianka can be positive. And drug-induced vasculitis, hydralazine, propyl thiouracil can cause. There also Pianka can be positive. And good posture, you have anti-GBM antibodies. Okay, doc? Now, giant cell arthritis. What are the key features? Jaw claudication and the vasculitis involves aorta. Aorta gives rise to carotid. Carotid gives rise to internal carotid. Internal carotid gives rise to ophthalmic artery. So ophthalmic artery involvement can lead to sudden blindness. That's the reason whenever an elderly person with a severe headache, with a throbbing, pulsating temporal artery, ears are high, don't wait and watch. Give methylprednisolone immediately, otherwise blindness will come. Takayasu arthritis may. Sweet, young-looking female who is Asian, subclavian will get stenosed because of the aortoarthritis. It involves the arch of aorta. It is a large vessel arthritis. Because of that, one subclavian become ischemic. So that blood pulse become pulseless. It's also called pulseless disease, where there is a weakened upper limb pulses and there is a BP discrepancy between upper limb of one hand and other hand. It will be 150 by 90 in one and other will be 100 by 60. Then polyarthritis nodosa may. There's an abdominal pain because of the mesenteric vasculitis, kidney involvement. Kawasaki is a pediatric patient with vasculitis. Strawberry tongue, coronary vasculitis, desquamation of the fingers, crackling of the sides of the lip, they are the presentation. Then already we know granulomatosis with polyangiitis vaginal, microscopic polyangiitis, then Church-Strauss, IgA vasculitis, then Behçet's syndrome. You have recurrent ulcers, uveitis is very common in Behçet's. Then Buerger is what? Thromboangiitis obliterans in the smokers. Typically smoking association. Here also there will be ischemia of the digits, like any other vasculitis. Now, giant cell arthritis. How is histology? Granulomatous inflammation, fragmented elastic lamina. Takayasu arthritis, there is an intimal fibrosis with aortic narrowing, large vessel. Polyarthritis nodosa, transmural fibrinoid necrosis. It can be early, active, healing, all different stages on biopsy. Then if it is vaginous granulomatosis, necrotizing granulomas with PR3 antibodies. And what type of necrosis? It's called geographic necrosis, like a globe. Then microscopic polyangiitis is leukocytoclastic vasculitis. there are no granulomas. And MPO antibodies are present, Pianka. Then Church-Strauss disease. There is eosinophilic granulomas, Charcot-Leyden crystals, eosinophilia will be found. Henoch-Conlin, mesangial IgA deposits will be there. Cryoglobulinemia. There is a low C4 immune deposits. And Melzar triad. What is that? Purpura, renal disease, neuropathy. Skin mein purpura, renal disease, neuropathy is called Melzar triad of the cryoglobulinemia. Kawasaki is pan-vasculitis, cytokine-mediated coronary arthritis in pediatric child. Strawberry tongue, right? Desquamating rash. Behçet's disease, neutrophilic vasculitis. Adi eosinophilic aithe the neutrophilic. HLA B51 association. That is Behçet's. So these 1-2 buzzwords about each. Go and see and attack. One vasculitis, you'll remember me in exam hall. So I leave the literature for you, doctor, for the vasculitis. So this is how you need to be very sure on rheumatology. I'm happy in about a couple of hours we are able to finish rheumatology. Right? Generally it takes 2 hours each system. Cardiology, nephrology, neurology, endocrinology, pulmonology, rheumatology, oncology, acid-base disturbances. 9 branches are there. 9 into 2, 18 hours, maximum 25 hours. उससे ज्यादा कोई जनरल मेडिसिन पढ़े तो या पढ़ाए तो वो बेवकूफ है. Right? So that's the reason. Let's not. So time is important, doctor. Don't read more than what you can remember. That is a secret. Okay. So see you all at tomorrow 12 p.m. Any changes, I will update you. Right? Thank you. Thank you all to the online students.